Hello, hi and welcome, and thank you for logging on into our multi-ethnic webinar discussing all things COVID related. This is very much an interactive event to enable you to ask any questions or share concerns you may have about the vaccination, long COVID and the booster vaccination programme. So my name is Siobhan Cranjanasa, but we haven't met before, and I work for the Ipswich and Suffolk Council for Racial Equality in conjunction also with the with the East Suffolk and Ipswich CCG. My role really is to engage with our multi-ethnic communities to ensure that their voices are heard at an official level regarding health inequalities. So if I could just now introduce you to our panel this evening, if I can ask Michelle to introduce herself.
My name is Michelle Claridge. I run ISCRE Pharmacy. I've been doing that for about 9 years now, and that is a normal dispensing pharmacy. Alongside that, since January, we have been running the ISCRE Pharmacy COVID Vaccination Centre, which has been involved in phases 1 and 2 of the vaccination campaign and has now gone into phase 3, continuing to offer first and second doses to anyone who requires it, and having commenced the booster vaccination programme for those that are now due.
Now if I can introduce Sarah.
Hi, I'm Sarah Fowler. I'm a respiratory physiotherapist. I was leading the respiratory physiotherapy outpatient department at Ipswich Hospital prior to becoming the co-clinical lead for the Suffolk and North East Essex Long COVID Assessment Service when it was developed last November and went live in December last year. So that has been my primary role since then.
Hi, Dean, if I can ask you to introduce yourself.
Yeah, hi, I'm Dean. I'm GP in Ipswich, also on the CCG sort of governing body, leading on social prescribing, sort of in the work streams for inequalities, among a few other things, personalised care and that sort of thing.
Thank you, Dean. And Lolu, if I could ask you to introduce yourself.
Hello, I'm Lolu. I'm a GP in Ipswich as well, and also on the governing body of the Ipswich and East Suffolk CCG. And leading on children and young people's health and on maternity and sexual health.
Thank you guys. So I'd like to introduce Sarah now again to come forward, and she's going to talk about long COVID.
So I'm going to talk around a little bit around long COVID and also around the service that's been set up for long COVID within Suffolk and North East Essex. So it's an ICS wide service. So going back to basics really, so long COVID has been defined as signs and symptoms that develop during or following an infection consistent with COVID-19 that are persistent for 12 weeks or more and can't be explained by an alternative diagnosis. And this is the definition that was published by NICE, SIGN, and also the Royal College of GPs. Long COVID presents itself as a cluster of symptoms that overlap with each other, come and go, wax and wane in terms of their severity and which symptoms are most severe and most prevalent. So it's quite a difficult beast to pin down, and it can be quite confusing for patients, for their families, and also for employers, I think. There have been a variety of estimates around prevalence, but anything up to 13% of those who've had a COVID-19 are potentially could have symptoms longer than 12 weeks and fall into that long COVID category. Long COVID probably isn't one thing, it's at least 3 things, maybe 4 things. The severity of the symptoms of COVID at the point of infection does not seem to be related to your likelihood of developing long COVID or the severity of the long COVID you then do develop. So we're certainly seeing what you might call a post-critical illness population, so patients that were very unwell and hospitalised or on intensive care. they are having ongoing symptoms, but we're also seeing, and the vast majority of our patients through the service are those that were managed in primary care and didn't actually come into hospital. The list of symptoms that have been associated with long COVID is so extensive that I couldn't possibly list them all here, but certainly the things that we are seeing very prevalently are fatigue, breathlessness, which is unexplained, feelings of brain fog, sometimes associated with anxiety, depression, poor sleep, palpitations, extended loss of taste and smell, dizziness, hair loss, voice disturbance, and that just is a few of the symptoms that we are seeing. So it is really a very sort of broad range of things. So what's the situation within Suffolk and North East Essex? So NHS England put out guidance that all geographical areas needed to plan to have a long COVID assessment service live by the beginning of December 2020. So this was in November last year, so we didn't have a lot of time to plan. So we spent 4 or 5 weeks kind of planning as well as we could, and then did go live on the 1st of December 2020, and that was with a team that was essentially AHP led, so physiotherapy and OT led, with a little bit of GP input, which we've developed since then. I'll talk about how things have developed since, and also some involvement from our speech and language colleagues and our colleagues from the chronic fatigue ME service as well. So essentially a System 1 unit was set up for long COVID, and a questionnaire was developed pretty much based on the Yorkshire screening tool, which has been suggested by NHS England as an appropriate tool to use. So that was embedded into the system, and a digital GP referral was developed. So all of the referrals come through primary care, through GPs, and they all come through a single point of access through the Care Coordination Centre, and the staff are our admin team essentially. So they manage referrals, they make sure that all the appropriate things have been done to accept the referral, and then they manage the appointments for the assessment team. So we do need some bloods doing before, as part of the referral. If patients, as per the BTS, British Thoracic Society guidance, if the patients are having respiratory symptoms at 12 weeks, we also need a recent chest X-ray. What we do not need is a positive PCR. That was very clear from the outset. Testing was not available widely when some patients were clearly becoming infected, and we don't require a positive antibody test. We do an antibody test, but that's really just for a clinical reasoning rather than anything else. We would not require a positive antibody test in order for a referral to be made. And I think that's one message that we've been trying to communicate as widely as possible. Because early on, certainly, we were finding that people had been told that they couldn't be referred because they didn't have positive tests. So we constructed the assessment team, which is multidisciplinary, and then we also then set up a multidisciplinary team meeting that happens once a week. So patients are assessed by the assessment team. They have a detailed discussion around the symptom profile of that particular patient. They are also at that point given appropriate guidance and advice. So some of that is information that's available digitally, but we've also developed as a service patient advice leaflets as well that we can send out to patients. So they get appropriate advice, and they also are then referred on to existing services that are relevant for them. So the services we've been referring on to a lot are the chronic fatigue service, respiratory physiotherapy outpatient department, because we're finding a high prevalence of breathing pattern disorder in these patients where they have unexplained breathlessness. Lung function tests and chest X-rays, etc., are are not remarkable, but they're still experiencing breathlessness. We're also referring to IAP services quite extensively for well-being and to support anxiety and depression type symptoms. But all the patients are discussed in the MDT. For a lot of those, it's very much sort of just kind of making sure we haven't missed anything. For patients that are slightly more complex in their presentation, then from the MDT, at the moment, we may go back to the GP and ask them to consider requesting further investigations or referrals. Unfortunately, at the moment, we are not able to do direct referrals from SNELCAS or request investigations. We are hoping that that is going to be something that changes once we further bolster our GP time within the service, and that would be supported by the CCC admin team. So until kind of the summer this year, it was very clear that the NHS England ask was for an assessment service and not a treatment service. And then in June this year, another tranche of funding was released, and we had to put a plan together to how we would use that allocation. It was allotted based on case rates, and it was split. So some of it was directed at primary care and is available for GP practices to access to improve the sort of communication and the knowledge base in primary care, and the rest was directed at the long COVID services. And that was to help try and support existing services that we were sending a lot of referrals to, but also building both the assessment and the treatment offer within the long COVID team. So we had a very short period of time to turn that around and have it signed off by region and then NHS England. So the way that we have gone about that locally is to try and do a couple of things. Firstly, to try and get more resource into the assessment team, so to employ more staff in the assessment team, so that we can start to actually take some of the long COVID treatment in-house, and that would help support some of the onward services. And the second thing was to kind of offer resource to those existing services to try and improve their ability to cope. And probably then the additional thing we did was to try and look beyond the limitations of the healthcare side of it. So there are various things that we've allocated funding to, and that is around alongside the sort of medically led MDT is setting up what will be a much more therapy and social prescribing type multidisciplinary team. So each geographical area will have a social prescribing link worker embedded in the team, and they will attend MDT meetings. And we also appointed a care coordination role, so that's somebody who will be able to support patients navigate through the system, particularly if they're being connected to quite a lot of different systems. We also went out to find out what potentially was already there that we could link with, or what programs we could fund that potentially could be useful. So we've got a variety of things that we're getting off the ground now. We've got a music therapy group that ran as a pilot, and we're just about to get the outcome of that, the pilot data. And we're wanting to look at funding that moving forward. We've also got connections with some other creative projects. So one is an arts-based project, one is a dance-based project, but also looking at working with people like Suffolk Mind and some of the physical activity offers to develop an appropriate support package for long COVID patients around anxiety, sleep, and very sensitively focused return to very, very low level physical activity and body movement in general. So because that's an area certainly clinically we need to be cautious, because some of these patients are definitely presenting with a post-exertional malaise picture, so they are having a disproportionate response to physical activity, so we need to be careful. We're recruiting a psychologist, clinical psychologist, to come into the team as well to sort of bolster things from that perspective. Because of the numbers, so we went live in December 2020. We've had 800 patients through the service to date, and you know, the referral rate is pretty stable and steady. So you know, we're getting, you know, quite a number through, and we've got to once they've come into the service, we also have to follow them up. We are looking at other ways of supporting patients and making the best use of clinical resources. So we've just gone live in the last 2 to 3 weeks with a long COVID digital app. It's called Living With. This has been developed by a company that already was in the digital healthcare space, but they've developed the long COVID offer with Barts and UCLH in London, and it's a way in which patients can monitor their progress. They can access resources to help them to support their self-management, but also I think one of the things that's most important with use of that app is that patients can directly message the clinical team. So if they've got a question or a worry or a query, they can directly communicate with us and us with them, so to improve the support. We're also looking at, and we're hoping to go live next month with some virtual group consultation work, and also some group education around some of the most common symptoms that we're seeing in the long COVID presentation. We do have in each of the 3 geographical areas, we have both virtual and face-to-face offer. So we're finding that people tend to fall into 2 groups. You know, either they definitely want to see someone face-to-face, or they definitely don't want to. So we should be able to offer whatever it makes most sense for that patient. What I will say, because I think it's relevant probably to this group, is that along with all of the long COVID services nationwide, what we're not seeing is the patients, the people who are coming to the service do not reflect our population, our local population. So we are seeing predominantly women, we're seeing predominantly white women, and we're seeing predominantly the age group between sort of 35 and 55. And that is not unique to this service. It is something that's been reflected nationally. And so one of the things we need to ask ourselves is, why is that the case? You know, long COVID is a new thing, so it could be that this is what long COVID looks like. But I think we need to scrutinise that assumption and say, it seems, why would it be? And how can we make sure that the access is easier or works better for those populations that we're not currently seeing? And certainly, as you know, the long COVID service, we would really value creating any links with anybody who can help us in those areas, to really make sure we get the message out in terms of what we can deliver. The only other thing to add, I think, before I be quiet, is that we are involved in various research projects. So with Anglia Ruskin, University of Suffolk, and also in-house with ESNEF. So there are a variety of research projects that are also going on within this, within the long COVID sphere.
That's great, Sarah. Thank you so much. It was really, really interesting. I was just wanted to pick up on your last point about the patients coming through not reflecting the population of Suffolk, and I was wondering if there was any correlation there at all, because we saw when the pandemic first struck that there was a disproportionate amount of minority ethnic people affected by the infection. But is this not the case with long COVID?
It's not who we're seeing. It's not who's coming through the GP channels. So I think we need to ask ourselves why that would be. Is it because we're not communicating the message effectively? Is it because there are barriers in primary care for people to get referred? Or is there some other explanation? But no, we're not seeing a cross section that we would expect.
And I just wanted to ask Dean and Lolu, is this the case for you guys as well within a clinical setting in your GP practices?
I mean, yes. I mean, both Lolu and I sort of work in a fairly sort of urban setting, and sort of use language line probably sort of every hour. The pathways to get to a long COVID clinic are multiple. So first, you need to have access to your GP. You need to have sort of access to sort of to testing. The access across all pathways to get into primary care, and to be quite honest, to get into sort of any of the NHS services, is sort of lack of access disproportionately affects the poor and those from minority ethnic sort of cohorts. The difficulty we have is that these are problems that have been affecting the system for decades, and unfortunately that's why you had not only disproportionate infections but disproportionate consequences for the minority ethnic sort of population. Then on top of that, you have the inverse care law, which unfortunately says that as soon as a new service is opened up, it is preferentially accessible to people who have the means to access, who can be probably a bit more forceful with their GPs, and who sort of demand the care that we all sort of deserve. Not victim blaming in a way. It's, for example, it's easier for me to say, no, you'll have to buy your over-the-counter paracetamol to a sort of a poor person or deprived person than it would be if I were to do the same in a surgery that's a bit posher. And I do some work in both. So I do work in pretty places, and also in places that have sort of a few sort of challenges. So I think, going on to solutions, which is what we're here to discuss, I think the first solution is to, from a patient perspective, probably to get out into the communities and to say things like, one, long COVID is a thing. Two, that it's not something like that you have to just work through yourself and step up. There are solutions sort of to it, because the thing about giving somebody's choice is that they have to know what options are available to them, and without the I would anticipate that if you did a poll of the poor parts of our system or the more ethnically diverse part of our system, there would be a total there wouldn't be awareness that this actually sort of exists, or that the access point is through your GP. The second bit of it would be the GP's response to it, and to be quite honest, we have to put our hands up and say that possibly the services within the more urban areas are probably a bit more challenged, and that's just going from personal experiences of working in sort of multiple settings. So there has to be, if we're focusing on solutions, some work to probably advertise that statistic. That I mean, to be quite honest, in sort of setting up the service with the acute sort of sector and with social prescribing and with Louise and our team, you sort of anticipate that when you set up any service, be it Singing for Health or any sort of that you will get this rush of people that deserve the service, but they will, and it's a bad word, they will outcompete the people that probably also deserve the service, but through multiple problems don't sort of access the service. So there probably needs to be an education program for those parts of our system that probably have low referral rates into the service, to understand the diagnostic criteria, to understand the effectiveness and outcomes of the sort of the service. So I think the problem is historic, in that the same problems that come with accessing diabetes care, high blood pressure care, is exactly the same access and trust problems you have with accessing sort of this new service. But also I think there should possibly be an outreach from the CCG, and I'll certainly be taking that up with Louise and our work stream, saying, well, the people that are low referrals coincidentally also occur in the places with the highest COVID infection rates. So there is our program of events is called What Are We Missing? And that seems like a gaping what are we missing that needs to be sort of addressed. So from a system level, we'll sort of be taking that up, both to get the information out to the surgeries, but also to the our communities sort of as well, because I think it's probably a two-sided sort of model of how to solve it.
Brilliant, thank you. Thanks, Dean. So I also had a question, Sarah, if that, and also to Dean and Lolu as well. Is this similar when we look at other autoimmune, diseases? So if we look at fibromyalgia and ME, is the demographics quite disproportionate there as well, as you say?
Yes, I would. But I mean, but as I said, long COVID is several presentations, not one. Yeah. So of that presentation, yes, it would fit that demographic, I think. Yeah, would be my take on it.
Okay.
Yeah, and the other thing that I would add is also an underreporting. Well-to-do patients will, will present, will be investigated, and we will get, because autoimmune conditions are typically challenging they present with initially vague symptoms, then there's a bit of an escalation. We investigate deeper and deeper and deeper until we find out what's going on. It's a bit of a stereotype, but unfortunately some stereotypes do have some truth to them, in that even for psychiatric conditions, same sort of pattern. You do get a sort of underreporting that tiredness, fatigue, malaise is not initially seen as medical in nature. So it tends not to get presented sort of in a medical setting. So yes, there are. Although there may be, I think, predispositions, I think the social aspects of things probably plays sort of a bigger role. And it is heartbreaking that although certain communities are more affected by the infection, the consequences of the infection, we are again seeing a fall off there. So it's something that we probably have to face as a system and try to solve.
We are going to be able to, I think soon, because we're extending our sort of data dashboard, we are going to be able to, I think, look and see the referral rates by GP practice. So it may be we're able to start to see where predominantly those referrals are coming from, and actually kind of approach GP practices to have those conversations. The only other thing I want to say is that I think that where we haven't got things right across the board yet. Somebody from another service said something that resonated with me the other day. We're building the plane as we're flying it. So we're making mistakes and we're trying to learn from our mistakes. But one of the areas we definitely haven't got right yet, and we need to really consider building a local strategy for within the long COVID services, is the presentation of POTS. So the postural sort of presentation. And at the moment, I think those patients going under the radar, and we haven't found anyone who really wants to own that clinically, locally at the moment. The cardiologists don't really want to own it. And I think we're going to need to develop our skill set in that area and actually develop a treatment approach to manage those patients in-house, because at the moment I think they're kind of falling between the cracks. It's definitely something we need to consider and work a bit harder on.
Can I just add something, just going back to what we were talking about with regards to InReach, and also almost, I know it might seem a bit counterintuitive for a service that is already quite oversubscribed to go looking for more work, but just by recognizing the fact that from statistics, we know that there will be lots of people undiagnosed suffering with long COVID who are not getting the support. I really just want to add my support to the fact that we do need to go out into communities and bring awareness of this as a condition. I think you will find a lot of, as Dean alluded to, a lot of immigrant communities just don't recognize those things as something to be investigated, or if maybe they presented once and had blood tests that were normal, won't come back, or especially if it's a mental health presentation, so if it's anxiety or depression, or they won't necessarily call it that, or even own up to that. So and then when you're thinking about your virtual group consultations that you mentioned, Sarah, using those as a way to perhaps deliver some of what you're doing in the clinics to those communities creatively, in a way that allows them to access it. Some of those communities, when can't get, I know in our surgery, for instance, people who can't get off because they start work at 6 o'clock in the factory and don't finish till 7 p.m. What kind of intervention, and they don't get paid to not go to work. So whatever we design for them, for that community, has to be designed with the community in mind, and actually with getting representatives from the community to co-produce and design what the same service that we've been offering so far to a certain group of people, what does it look like for other groups of people that don't access services the same way. So I think it's a lot of work, but I think work well worth doing when we think about the long-term impact this could have, not just on people's mental and physical health, but even on our community's economic, well-being, all those other things, all the knock-on effects of people being unwell and not having, properly been attended to, whether that's psychologically or physically.
Thank you, Lolu. Thank you very much, Sarah, and thank you for the discussion. I found it really interesting. If anybody has any more questions for Sarah, we will move on to Michelle.
Thanks very much. So my slot is about the COVID booster vaccination programme. In terms of who the booster programme is open to, the Public Health England guidance. So the booster vaccination programme is aimed at those that are 50 years old workers, those who are of any age, so younger people at risk who have underlying health conditions. One of the most important things with regard to the booster vaccination programme is that there are still many people who haven't sought their first and second doses. And again, though that seems to be disproportionate with regard to the communities who have had the most serious effects with regard to pre-existing underlying conditions which have put them at greater risk as a result of COVID vaccination, and that many in the BAME communities are not accessing the primary vaccination courses, which are so important to reducing the consequences of COVID disease, both individuals and communities as a whole. So I'd really like to stress how important it is for all those that are eligible to access the primary vaccination course and ensure they have done so, and then also those who are eligible for the booster vaccination programme to do so. The booster vaccines are being delivered 6 months after the second dose. The JCVI guidance and the Public Health England guidance is very stringent on this, and that 6 month interval is.
Hi. Yeah, I'll give Michelle some time to come back. I think she's having some connection issues as well as having a really poorly sore throat at the moment. I've just got a few questions actually. I was going to ask our panel if they know the answers to this. So, is an individual still fully vaccinated even if they don't have the booster jab?
It's a tricky one. So just sort of as Sarah mentioned about building the plane after you take off. That's the unfortunate but unavoidable situation we find ourselves in with COVID. This is not JVCI guidance, but there is some evidence that a COVID booster, a COVID vaccination program is probably going to be what we call a 3' series. So there are some vaccinations that you only need one, and you're fine. Some you need two, but it looks like COVID may need three as a booster, because you do get that waning immunity. The second bit is that most of the guidance came out when we were dealing with the Alpha variant, one of the first variants, which was far less infective, had far less viral loads, and to be quite honest, made people a little less sick than the Delta variant does. The other bit about it is, just like we have to have an annual flu shot, because these viruses are fairly clever, so they keep changing to get around our defenses. The difficulty is that we cannot sit on our laurels and think that because we have, let's say, a 97% effectiveness that Pfizer had against the Alpha variant, that wouldn't drop off, because the Delta variant is just a smarter, more deadly virus, so it drops to 80%. So what we tend to do is that we, at the start of the pandemic, we concentrated a lot on how effective the vaccines were at preventing infection. But in actual fact, having a mild infection is not too bad. But an infection progressing to disability, long COVID, and death is at the end of the day what people and what clinicians want to avoid. So I would probably admonish everybody to get the booster, because Delta has changed the game, and unfortunately there are other ones coming along possibly not as widespread as Delta, like the R1 and that sort of thing, that will change the game again. For us to stop the variants from happening, what we have to do is to get as many people vaccinated as possible, so that the virus doesn't have space to experiment and find ways around our immune system and around our vaccines. So it's no longer thought that the 70% that you would need for most viruses is enough. We have to be looking at getting close to 80 to 90% coverage of the population, so that we can protect those in our communities, because the problem is that our younger people who feel, well, it's just going to be a mild infection for us, we have to make the point that it's not just about you. It's, yes, you will have a risk of dying. Yes, you will have a risk of long COVID. Yes, you will have a risk of getting admitted to the hospital, but we have to start thinking of all of our communities, all of our families, the vulnerable and the elderly who cannot defend themselves as well as the young people. So a short answer to to my long sort of answer is yes, a booster, I would say, is absolutely essential to protect both yourselves and your community and your family.
Thank you, Dean. Thanks for that answer. Michelle, we'll come back to you. You ready for us to come back to you?
Hello. Yes, I'm back. I'd absolutely agree with everything that Dean has said there, and very, very well put. So with regard to co-administration of the COVID booster and the flu jab, so the guidance now is that the booster can be given together with the flu vaccination. When the COVID vaccinations were given initially, they were a new vaccination, so it was important that we could ascertain what additional effects in a large population basis hadn't necessarily shown up early on in the research and the studies, and so the waters weren't muddied by having additional vaccinations within that 7-week period either side. Obviously, with having the broad population vaccination, there's a huge amount of data that would have been collected along the way, and so it is now felt that it is safe for the flu vaccination to be given at the same time. They're both inactivated vaccinations, so a lot over decades has been known with regard to use of inactivated vaccines, and that they can be given safely together. And in terms of people getting appropriate protection from both COVID and the influenza virus as we move into the winter months, and relieving those pressures on secondary care and hospitals, and preventing deaths either from COVID or severe influenza, it's really important that people do get those protections, and they can get those both at the same time, so they're not needing to make multiple appointments or multiple trips and potentially missing either one or other of those protective vaccinations.
Hi, thank you, Michelle. Yeah, there's a question that Sue has put in the Q&A box. Is it only Pfizer vaccination being offered as a booster?
Currently, it's Pfizer. From the 15th of October, it will be Pfizer and Moderna. I'm unclear at this stage whether AstraZeneca will be included formally in the booster programme. Certainly the vaccination centres need to be in a position to be able to administer any of those vaccines as part of the booster programme. But as yet, AstraZeneca hasn't been commissioned as part of the booster programme. Where that may differ is if individuals have severe allergy or anaphylaxis to either the Moderna or Pfizer vaccinations, because they both use the same technology, and in those circumstances it would be necessary to have a different technology such as the AstraZeneca. But there's no clear programme that's been laid out with regard to using AstraZeneca at this point in time.
The one important thing to say is that the availability of which vaccine can be used as a booster sometimes is controlled by just how quickly whichever manufacturer is testing and getting the research on their particular vaccine. So the reason that Pfizer and possibly Moderna have sort of a license to be a booster is not down to safety or effectiveness or anything like that. It might just be how fast their researchers were able to get approval. The one thing that I would say is the best vaccine is the first vaccine that you can get your hands on. The best booster is the first booster that you can get your hands on. You don't want to be waiting for your preferred Johnson & Johnson because you like the name or the branding of it, and then 1 or 2 days before you're standing in the queue, either you or a loved one gets infected and suffers the consequences. So the best vaccine is the vaccine that you can get your hands on. The safety profile of them is actually quite remarkable compared to all the other vaccines that we give. It's one of the in a lot of ways I suspect Nobel Peace Prizes will be won for this one, in terms of how quickly the world experts and scientists got together to deliver safe and effective vaccine. So as I say, the best vaccine is the next vaccine.
I'd absolutely agree with that, and the reason they've been able to bring these vaccines to market so quickly is because they've been using information that has been available for decades to be able to deploy rapid testing and rapid development to bring these life-saving interventions into place. So yeah, I'd absolutely agree with all of what Dean has said there.
Brilliant. And Sue was just asking as well that does it matter if, for example, you had AstraZeneca as your first 2 jabs and then you receive Pfizer as your booster?
Absolutely not, no.
Oh, that's good.
No, your immune system just needs to learn. So it doesn't matter which teacher shows up in the classroom. Your immune system will learn how to defend itself because of the vaccine, and it will protect you against all known variants that are going around at the moment. And I think the critically important bit to say is it's not about just preventing infection, okay? If you got infected and you had a cold, a flu, and that was fine, and we could guarantee that would happen, then to be quite honest, none of us would be here tonight. It's the fact that this is a deadly virus. It has killed a lot of our communities, and even in those that it hasn't sort of killed, you do get quite sort of nasty sort of consequences. I know several people, several families who've lost vaccine hesitant sort of people. So I would just say, to protect yourself, to protect your family, please get your boosters.
I've just got one last one really, Michelle, for you, and it's regarding the flu vaccination and the COVID. If you're receiving your first or your second jab, can you have your flu vaccination at the same time as those as well?
That's a really good question. The co-administration has come on for with the booster programme in mind. I would not say that it would be unsafe, but I'm trying to think through the templates. Dean, can you remember what it says on the templates?
Yes, and I've read lots of templates. Yes, they're absolutely safe to give together, both as a booster and as a first course.
Okay, well, we're running out of time now. It's been really interesting, and I really want to thank you all for all the input that you've put in. We will be sharing this recording out in all our communities. We'll be sending it to all our partners and into the voluntary community sector as well. So it will provide valuable information. And as Lolu and Dean and Sarah, you stressed before that it's really important now that we start working with our communities, especially around long COVID. But there's still a case that we do need to work with vaccine hesitancy within our communities as well, as that still it is an issue within in some communities. But thank you again for coming, and we look forward to seeing you at our next event. Take care.
Thank you. Cheers. Bye.